to start off with, I mean, I've already said myself that I used to be a nursing home manager for 5 years, so I certainly have an appreciation around what it's how it is to work. Although it's a long, long time ago, and I'm sure many things have changed since I was a care home manager in central Birmingham many years ago. But care homes are an essential part of our society and our communities. They absolutely are an essential part of the health and social care system which is in the country, and they're always at the very top of a lot of the agenda politically, and discussions around health and social care bills, and financing and funding, and how our health and care system works. And care homes, obviously, certainly in the last 2 years, have had an incredibly difficult time, which I think we all on this meeting should be appreciating, on this event today, should be appreciating the incredibly difficult 2 years of the pandemic that care homes have worked through in the last 2 years. And with that, it's never been more recognised up here, the dedication and the amazing staff across the sector around working in care homes, and those staff. We saw things in the media. We saw some care home staff spending time living in the care homes for a number of weeks, if not months, to support the residents of care homes. So part of today is a real recognition of, and being very clear of the immense work that care homes do across the health and social care section, nationally as well as locally, of course, in the Black Country. And as stakeholders today, that I'm really hoping that the next 2 hours will highlight and future enhance the work and support that hopefully the Black Country Health and Care Foundation Trust, through its InReach the Care Home service, can work collaboratively and supporting those people with the most complex needs around mental health within care homes today. And that is the purpose of today. Hopefully that we will be able to work very collaboratively in supporting and highlighting and enhancing the work that we do within care homes, coming out of such an incredible last couple of years as well. Next slide, please. This is, I've just mentioned, obviously, that care homes are an essential part of our society and communities in the Black Country. We've got some older adult population figures here, which we used when we were developing and designing this InReach the Care Homes service offer, looking at populations. Now, those populations are the older adults. We can see in Dudley, these might be a little old and from an older census, perhaps, because I've heard other figures brandished around for numbers and figures of populations, but it gives us a starting point and an idea about the number of older adults that live within the Black Country in each of the localities, in each of the boroughs. And with this as well, we looked at, when we were developing this work, we looked at the number of care homes in each of those localities as well. And it isn't really, the numbers of those care homes, they're not too far apart. Walsall has 58 compared to Dudley and Wolverhampton 71. These numbers as well, I know, are very changeable. That some care homes close, some care homes open. We have very large care homes that might suddenly open with quite a large number of beds. But roughly, it's not too far apart, the numbers. So around between 60 and 70, you could say, numbers of care homes in each of the boroughs, which of course is an important part when you're trying to look at developing services, which is going to support care homes from a mental health point of view, about the numbers of care homes that there are. And also, it's being clear on what those care homes provide as well in each of those boroughs, which has been really quite difficult over the last couple of years, obviously because of the pandemic and all the other work that we've had to be involved in during that time. And here we have the number of beds. I have to apologise to anyone who's here from Sandwell today, that the number of beds, we tried a lot to look at the number of beds in care homes in Sandwell, and it was really quite difficult to get those figures, and apologies that I didn't have those figures for today. There's always been some confusion around Sandwell and West Birmingham figures, over the years in population and things like that. So I do apologise for anyone in Sandwell that we didn't actually get the number of bed figures, but I can imagine it's probably very, very similar to between 2000 and 50, between 2000 and 1500, as you can see from those other figures as well. Next slide, please. Okay, so a bit of background. I've already mentioned about this project and about in reach to care homes briefly. In Dudley in 2015, the CCG, the Clinical Commissioning Group in Dudley, aspired, as we have for years and years, keeping care closer to home and reducing the amount of admissions, particularly into dementia assessment wards, but not exclusively. And certainly we all know that, the disruption of moving people from their home, be it their own home or be it from a care home, into hospital in any type of hospital setting is really, really quite a difficult time for people, particularly with the dementia, and going on to a dementia assessment ward, which are needed. We do need to have a dementia assessment wards and dementia assessment beds for people. But we really aspired to keep those numbers as low as we possibly could. For a start as well, to have as few people on the ward is also enhances the environment for people when they are on a ward. Instead of when I started in my training all those years ago, the minimum on a ward used to be about 20 people with dementia. And certainly nowadays we try to keep it much lower, around 15 to 10 people on the ward. So that was part of our thinking, is in how do we reduce the amount of people on our dementia assessment wards. And we did a study with the CCG, which included medical staffing. It included our medical staffing and the ward managers, the community team. And we did a study and we looked at how people arrived into the dementia assessment wards. This was at Bushyfields Hospital, Holyrood ward. And we discovered that a lot of people weren't often very well known to the CMHT, the Community Mental Health Team. Or if they were, it was only a short time prior to their admission. And a good number of the admissions that came into the dementia assessment ward came through A&E or directly through an acute medical ward. So we had a number of people presenting at A&E who were unknown to us or unknown to us for a very short time. And they would go through that medical route into Russell's Hall Hospital. And then they would find themselves being admitted into Holyrood, either directly from A&E or AMU, or maybe from one of their medical wards as well. Of course, we did have other people who were being admitted from their own homes and people being admitted directly from care homes as well. So a number of these people who were coming into A&E or through the medical ward route were people who were coming from care homes as well. And it may have been for physical health conditions, or it may have been in a number of cases because of a delirium. It could have been also a number of cases because of their distress that they were displaying at the time. And at the time, it was identified that we were seeing a number of admissions indirectly from care homes through that acute hospital route as well. So what we wanted to do when we were looking at how would we look at trying to minimise this minimise the distress, obviously, of those service users or those patients or those residents who were coming through that route and coming into our assessment ward. One of the things that not just locally but nationally as well, there have been in reach to care homes type services that have evolved and developed across the country to try and look at supporting people with the most complex mental health needs within care homes, especially those people with dementia, as quite a majority of the people that in reach care homes will work with, but not exclusively. So at the time, the CCG invested into in reach to care homes registered mental health nurses, qualified nurses, to be part of the CMHT. And this was also following a couple of years before that, or a year before that, we also had a community mental health nurse practitioner for care homes who was working within the Dudley Group, within the nurse practitioner team within Dudley Group, who was also an RMN, senior RMN nurse practitioner, who was very much involved in working around supporting in education hopefully in education and early intervention and detection of people in care homes as well, who were presenting with mental health needs that were going to need to be stepped up to more complex support from the CMHT. Next slide, please. So that was a bit of background, and the aims of that service was to provide a dedicated resource for care home residents that has a focused response around the needs for mental health assessment and treatment. So we've always had CMHT staff going into care homes, and this was in Dudley, but this was somebody who was dedicated to care homes, and their focus was a dedication to care homes, because obviously that same CPN historically in the past would have been seeing people in their own home for a number of mental health assessment needs and treatment needs and dealing with crises. But this was something that we felt was very important in Dudley at the time, was to have somebody dedicated, if not a couple of people dedicated, to focus specifically on people in care homes. It was for medication reviews and monitoring the efficacy of medication, which is of course nationally has been a very, around the reduction of antipsychotic medication has been, also part of some of the need to look at in reach to care home type services from mental health. Physical health, delirium pain management. Now, care homes obviously do a lot of work already around this, but it's actually to add that mental health support around physical health as well, and interventions around physical health as well. So it's not to say that that doesn't already happen in care homes. It was to enhance all of that work around physical health, delirium management and pain management, etc. So the other thing as well is staff education around the approaches that in the assessment and the liaison with those care homes around that assessment and treatment would ultimately support mental health interventions, one would hope, as well, working with care home staff in supporting and developing their care planning for their residents with more complex mental health needs. Risk reduction techniques, because clearly a number of people who were being admitted to hospital were around risk and escalating risk, and also we do want to promote obviously therapeutic risk taking, but also around risk reduction to enable people to have as a minimal amount of disruption in their lives and changes around restrictive practices or having to move care homes or ending up in hospital. So certainly risk reduction techniques was another big area of the work and the aims of the services. Care liaison and sports, working with care home staff and working with families, around that liaison type of role as well. So going in very focused and very specific to that individual who was in distress or in crisis, but also supporting any other liaison support around the care home mental health needs and support. Comprehensive mental health assessment and risk assessment, that's where the mental health services, that's what we're here to provide and support around a comprehensive mental health assessment and risk assessment. That's core to the work that the CMHT and this in-reach care home work will do. And support care home formulation of person-centred care planning. Certainly person-centred care planning in dementia care and person-centred care planning in mental health has been around for a long time, and it really is in helping to support through the mental health interventions and assessment and treatment plans that to try and make that as person-centred as possible and support the care homes in actually providing those person-centred care plans. Signposting our knowledge and our access to signposting for further services, including access to the consultant psychiatrist and other opportunities around mental health, OT and psychology, and other signposting to ultimately, yes, we still do use assessment beds, as you'll know, so signposting and where admission is required as well, and support around admission. Next slide, please. So that was 2015. So fast forwarding on to 2020. So that service had been running for getting on 5 years, 4 to 5 years in Dudley. So in the autumn of 2020, the Black Country Health and Care Foundation Trust, we were successful in submitting an NHS improvement bid for transforming community mental health services, and this gave us the opportunity to build upon this gave us the opportunity to build upon the in-reach to care home service model, and make it more than just Dudley, and make it Black Country wide. So core to the bid was that older adult mental health services will further integrate and work collaboratively with local authority, voluntary sector, bringing synergy between physical health, older adult mental health, and psychosocial person-centred care. So those golden threads that ran through that bid were very much about how we work and collaborate and integrate with our other healthcare partners, of course, which care homes are very much part of that health and social care, and the local authority, and all of those other people, all other physical health as well, services were going into care homes. So the work that we'd already previously done in Dudley for the previous few years absolutely fitted the criteria to be included within the older adult element of the bid, and we were successful. So, and the element of the bid was to develop in-reach care homes services across the Black Country, building on the success of Dudley. And so that was absolutely fantastic news in the autumn of 2020. And if you look at the dates as well, you know, this was at a time when we actually were actually granted and were successful with the bid in January 21. We all know what was going on at that time still, and we were at the very start of the vaccine program, really, then, I think, wasn't it? But it's an incredible time for us to be having a community transformation and being successful and having some extra monies coming into mental health. So it has been quite a challenge. Hence, I think, you know, we're now obviously in July 2022. So there have been lots of work going on, despite, I should say, the pandemic, thankfully. Our next slide, please. So to roll out across the Black Country, to make this Black Country wide, we still have a finite amount of finances to use within the bid, and the bid wasn't just for older adults. The bid covered adult mental health as well across the Black Country, and there are a number of other elements in older adults within the bid as well. But building on the work from Dudley, we actually recognise, and if you think back to some of the figures around the numbers of care homes, the populations in care homes, we did look at obviously how we're going to resource that. So ultimately, we've got Dudley started off, as you can remember. Hopefully, we had 2 RMNs in Dudley in the ECMHT, which we still have, and Sandwell, we're going to match that with Sandwell, and I can see Tim's one of those 2 in Sandwell. I'll come on to progress to date. We've got Walsall with 2 RMNs in Walsall, and Wolverhampton 2. The thing that I'm so pleased to see as well is that following the bid has also given us the opportunity to develop it further. And the further development, although still within the constraints that we have financially, obviously, the other development is psychology, having dedicated psychology time and assistant time, because I know that psychology assistants have supported in-reach in Dudley historically, but there's never been anyone dedicated to that. And that is a dedicated link clearly to our clinical psychology as well. So having 0.5 as a psychologist in each of those localities, and what you'll find that there'll be one psychology assistant who will cover 2 localities. So it's not 4 psychology assistants, it's 2 psychology assistants, but with their work they're going to cover 2 localities. In Wolverhampton, as part of some of our financing and some of the work we were doing, we understand, we recognised in Wolverhampton that we could actually put in a further support worker, and this recognises in Wolverhampton there is a lower number of inpatient beds for dementia care, particularly, well, for both dementia and functional mental health in Wolverhampton. So that is something which we felt, if we're going to put a support worker anywhere, we'd probably put them in Wolverhampton because of the reduced amount, the lesser inpatient beds that we have for assessment, admission and assessment. Next slide, please. Okay, so I've already spoken about the aims of the service, and so I'll go on now into more detail around the model of the service as well. So staff within the in-reach to care homes will be integrated within each local enhanced community mental health team. So it was called a community mental health team previously, but with the likes of in-reach to care homes going into there, and other services, we are enhancing our community mental health team in older adult mental health, and one of the enhancements is to have those in-reach to care home workers, so they will actually be based within the enhanced community mental health team services. In-reach to care homes support those with dementia, as I've said, and those also with functional illnesses as well, such as anxiety, depression, bipolar, psychosis, etc. So whereas a lot of the focus will be around dementia because of the number of people with dementia that you find in care homes, it's not exclusive to just people with dementia. It does include those other mental illnesses as well. Referrals for the service users living in the referral access really is for service users living in 24-hour residential or nursing care who require medical reviews or management plans for behaviours that challenge. Though that's the whole point of this model, and in working in supporting. It's around those behaviours that people in care homes, the residents, other residents, and also obviously the staff in those care homes find challenging. And actually, this service is there predominantly to really support and help care planning around minimising risk, and also supporting people to live well with their dementia or other illnesses within a care home, and also supporting the other residents obviously within that community as well, by the focus and support for those individuals who may have be in crisis with distress and other presentations. The in-reach to care homes focuses around mental health crisis and those with complex mental health needs, so requiring mental health assessment and treatment. Through their interventions, in-reach to care homes will provide education and training to care home staff, as well as signpost staff for formal training opportunities potentially. One of the aspirations for this would be to do more formal training, but because this service is for really those people who are in acute need and acute distress, and who have complex acute illness and needs, a lot of their focus will be around the assessment and the treatment. Obviously, by going into the care home to support the care home team with that service that resident's distress, and looking at their care plan and looking at their treatment, and the interventions that in-reach care home worker will do, that in itself will hopefully in a liaison way support some of that education and training needs for staff. But it's not formal type of classroom training that they're able to do generally. There may be some opportunities, but it'll all be dependent on the amount of obviously face-to-face clinical work that they're actually doing with the residents themselves. So, but hopefully there'll be opportunities to identify training needs, and then obviously to look at how to support people, to signpost people to those training needs as well. Okay, so next slide, please. Due to the current resource in the in-reach to care home service, staff will operate between 9 to 5. So when I talk about crisis and those people in high need, one of the things that it seems incongruent to say, well, this is going to be a 9 to 5 service. In practice in Dudley over the years, that they have worked 9 to 5, and those are some core times where there's a lot of liaison with obviously other professionals and the MDT, that they're able to. If somebody has some presentations in distress, say, or behaviours that people find challenging, say in the morning or late in the evening, and I know people talk about sundowning as quite a common presentation, that they can be flexible to accommodate some of that some of that, but the majority of the work is 9 to 5 Monday to Friday. That's maybe something for the breakout rooms for further discussions as well. But out of hours and at weekends, we do have each of our ECMHTs now are working 7 days a week, and they are operating differently because remember, the Black Country all coming together is quite new, whereas previously there were 4 CCGs commissioning 4 different ECMHTs, and that's reflected as well how they were commissioned in the 2 legacy trusts in the Black Country Partnership and also in Dudley and Walsall as a previous trust. So they all operate 7 days a week. Sandwell is 8 till 4, Wolverhampton work 8 till 8, and Dudley and Walsall work 9 to 5, 7 days a week. So if anything, any other crisis falls out of that time, then that is picked up by the generic out of hours crisis services, the crisis services that are 24-hour, 24/7. But with experience in Dudley, having that further focus and that work with the InReach team, and also the 7 days a week ECMHT, we don't see a great deal of crisis falling out of those times, say at 10 o'clock, 11 o'clock on a Saturday night, etc. So it feels incongruent to have a 9 to 5 service in enriched care homes when we're talking about a lot of crisis, but in practice it does actually it does seem to work well with the body of the work, 9 to 5 Monday to Friday, and how that functions and works with the MDT in the CMHT, and also with of course other partners in the care home within normal working hours of 9 to 5. So next on that is InReach care home staff purposely have a small caseload of around 12 to 15. So if you think about a normal CPN who was going in maybe to care homes, they could have a caseload of maybe 30, maybe even 35, 40 in some places maybe 25. We've purposely made the caseload as small as we possibly can to allow that more intensive focus. And that caseload will have a number of different presentations on that caseload. They will have some people who are in very, very critical, urgent need, and they'll have some people who don't have to be seen quite as often, and others less often who we're trying to discharge out the InReach care home caseload. But it does hopefully ensure an intense focus, and it will also minimize time on caseload. Usually we'll look at around 8 weeks to discharge people. If anyone goes over 8 weeks from that caseload, then anybody over 12 weeks would be very, very surprising, or an exception, we would hope. What we've actually also identified that hopefully with the support and the intervention and around the care planning supporting the care home, a lot of those people will get discharged from mental health back to GP to the support from the care home, entirely through the care home with the GP, but also a rapid response back in if required and needed, of course. Some people maybe remain within the care of the CMHT, so there are some people who will be longer term supported and monitored on a monthly basis by the CMHT. If those people then go into crisis, then they will be back with the InReach to give that more intensive focus again. But thankfully, we do manage to discharge a lot of people back to GP and out of mental health services. Next slide, please. So access. I've talked a lot about the service. So access. I think one of the most important things to say today as well, that there should be no change for referrers to the InReach care home service, because currently all of those areas that don't have InReach care homes are referring people who are in critical need for the community mental health teams of Wolverhampton, Sandwell and Walsall. They are referring people to the ECMHT, whichever front door that ECMHT has, for a referral, predominantly from GPs. So that shouldn't be changing at all. because when they actually come into the ECMHT through that route, if there is an opportunity for the InReach on the same day, if it's a same day urgent referral, for example, if there's an opportunity, then they will go straight to the InReach. But if not, because the InReach are obviously doing a lot of planned work as well, then they will be seen in the crisis element of the ECMHT, and then as soon as possible moved into the InReach to care homes staffing. So it's the same for everybody. So there isn't a new number, there isn't a new address, there isn't a new email box or anything. So it's referrals as you would into the InReach to care homes service, as you would, sorry, into the ECMHT as you would normally. So that's some good news, and in the most confusing of times that we have, that doesn't change the referral address. So next we had community mental health nurse practitioner posts are under consideration in Wool. Sorry, yes, I should have said, I did mention earlier, in Dudley we do have a community mental health nurse practitioner who is working within primary care, and we also have something similar within Walsall, working within the integrated physical health service in Walsall, and they will work very, very closely, obviously, with the InReach to care homes team, and they will be able to refer immediately into the InReach teams as well through the ECMHT through that route. Those posts are under consideration in Wolverhampton and Sandwell at the moment, but we don't have them in Wolverhampton and Sandwell at the moment. So when referrals are received, they'll be screened and triaged and allocated to InReach, as I've said. InReach have access to old age consultants, the medical team, obviously in the part of the CMHT. They have access to occupational therapy in the ECMHT, and they also have access to psychology, which of course is now enhanced by having our psychology assistants as well. Although it's admission prevention, they will also facilitate admission to mental health wards, and they will hopefully support also if people have to step up into a higher level from residential to nursing or a mental health nursing home, they will also support some of that with somebody who's in crisis, as well as support and facilitate admission to mental health wards, obviously as a last resort, but of course when it's required. Next, please. Eligibility. So service users with a diagnosis of dementia with complex presentation behaviours that challenge hallucination, psychotic features, and within a care home environment. I've also mentioned before those people as well, that they might have a dual diagnosis, dementia, as well, and also service users who have functional illness as well will be eligible. There'll be eligibility if they're certainly in need of mental health support and secondary mental health support. Service users require the input of the secondary mental health care support, psychiatry, community mental health worker, psychology, and the support to have support in that care home environment. Service users in placements currently under the care of yes. So we will have some people, again, like I said earlier, somebody may already be they might be under outpatients only. So they will also receive InReach if they need InReach to care homes. What this does, it does minimise the amount of need for those people to just be under a consultant, psychiatrist, old age consultant. It does tend to reduce that need for those to be like an outpatient with one of our consultants as well. But they would also be eligible for InReach to care homes. Next slide, please. I've got glasses on, and my glasses don't help me much with this. This is really for those people when we circulate this presentation, that people this took hours out of my life, unfortunately, with our really helpful PMO colleagues in trying to design this within the working group. It took a lot of work. It looks very, very complicated, but if any of you are interested in the very, very minutiae and the details about where people enter into the service and their route through into the service, it's basically looking at all the different entries which I've just explained, hopefully, about entering into the InReach service via the ECMHT, please, have a look at that. And if anyone's got like any questions at all, if you find yourself on one of those blocks on this slide, then and you're not quite sure whether this has been the right route in, we have a service specification in the making, and we also have an operational policy as well, which will help support, obviously, and this will be embedded within that as well as the pathway in. It looks very complicated, but for people referring externally and internally, it's through the ECMHT. It makes it a lot easier than having to look at that pathway. But please feel free, if you want to scrutinise it and study it and come back to us on any of the elements that you can see there. Thank you. Next slide before my eyes start to get too affected. So we mentioned earlier around Dudley, about some of the work that had been and some of the aims there, and some of the interventions we've been looking at within our working group, and from the experiences of Dudley and the new developments with the new service is life story work, hugely important. Crisis support, obviously that's one of the really big remits around InReach to care homes. Dementia care mapping, I would like to think that we would be able to train our InReach to care home workers in dementia care mapping. They wouldn't necessarily, for those people who know dementia care mapping, it's a very time intensive and time consuming, really valuable quality of life and assessment tool and observational tool developed by Bradford University that will allow a real understanding of the experiences that somebody with dementia is in any residential environment that they're living in. It might be one of our wards, we could use it in wards, it might be in a care home. I'd like to think though you can do a micro dementia care map, it's called micro mapping, whereas an InReach care worker could go in and observe one individual instead of mapping a number of individuals, which is the usual model, around a particular type of presentation that the care home is struggling to understand or to implement a care plan around. So micro mapping, I think that is an opportunity that we're hoping that some of our InReach care workers will have that as part of their toolkit around some of the observations, as well as utilising things around obviously the Newcastle model around interventions with dementia care and people's quality of life, etc. Medication reviews, we mentioned that earlier. Utilisation of various assessment tools. There are a number of tools that could be used around assessing people's quality of life and their around their presentation, particularly around some of their behaviours that they may be presenting. Care planning around advice, psychosocial support, carer support I mentioned earlier, staff support and education through their interventions, pain management, physical health interventions, and safeguarding, supporting around any safeguarding issues that are presented, person-centred staff training. That is something that will happen hopefully as part of the development of care planning for people as well, as I said, as a more informal training rather than staff classroom training. Next slide, please. So benefits, so prevent crisis through early intensive intervention to manage complex mental health issues, avoid unnecessary moves to alternative emplacements. So it will hopefully prevent people having given notice in a care home to move to another care home, prevents admission, as I mentioned, supports transition from home, inappropriate care homes, or so it also can support people who are going into who may be coming out of our inpatient ward into a care home as well. Promote quality of care and personhood, well-being, using person-centred care approaches, improve risk management, including inappropriate use potentially or appropriate use of antipsychotic medication, support the service users' family through education or signposting, improve diagnostic rates for dementia, because there may be some people who are presenting with maybe psychotic symptoms, and maybe there's a need to facilitate a memory assessment. for somebody, support discharge of more complex patients to care homes and repatriation from mental health wards, as I mentioned earlier, and reduce the use of antipsychotic medication is one of the targets where appropriate, or any sedating medication where it's possible to do so. Next. So progress to date. So we've had the model approved, obviously. We're out to recruitment. And we've got two people are recruited already into Walsall and are now up and functioning in Walsall. Wolverhampton, we have our support worker ready and waiting whilst we've got interviews. Hopefully we've got enough shortlisted candidates that we will be hopefully being able to recruit into Wolverhampton. Those interviews, I think maybe next week for those interviews, or maybe even the week after. One of the people's on leave, as we heard earlier, who's involved in the interviews. Dudley, we have 2 registered nurses already. We have in Sandwell, we have Tim at the moment, as you've seen earlier, and we also have a candidate or candidates shortlisted for that last vacancy as well. So, being the forever optimist, I'm hoping with maybe 2 months notice for people, 3 months notice, I'm thinking within the next 3 months we'll have a full spread of our in-reach to care home workers. Bear with us for those areas like Wolverhampton, which don't have anyone in post at the moment. There won't be much change at the moment. Well, there won't be any change at the moment, but when they come into post, we'll do a further comms for Wolverhampton, and also we'll let Sandwell know, obviously, when they get their person in post, we'll let you know. So then you'll understand, obviously, that we're now up and running and fully functioning. We'll do a comms for that as well. So all based, again, within the existing community mental health teams and within their bases. So accommodation isn't an issue either. Next. Next steps, we've got to sign off our operational policy. Strange doing a service specification as lead provider now, because we used to always get a service specification from CCGs. So that's a new experience for us. Outcome measures, we really want to see some outcome measures and key performance indicators, which hopefully some of those outcome measures and key performance indicators may come from today for some people's ideas, hopefully. And also get that reported through, we work through a RIO system, which is our clinical record system. So a lot of information we'll be able to get clinically from RIO, hopefully, through our BI portal system. And like I've said, your feedback during this event to take on board an action where needed. So we do really want to get as much feedback from yourselves. And I think, if my memory calls, next slide, that was the end of me. I'm sorry if that took quite a long time, but hopefully that was informative. And I can hand you over now to Angela Francis for the case study.
Hi everybody. Like I said before, my name's Angela and I work in Dudley CMHT. We've been enrolled since 2016. So this is a case study. It's a lady that has stuck with me for a long time. So I'd like to introduce you to her. Is it okay to turn the page, please? Right, we received a referral from the GP into the community mental health team. We either get a 4-hour response or a 5-day, sorry. As Nick spoke about before, if it's a 4-hour response, if we can respond, we do. If it is that we're tied up with other things, then our duty workers will respond and then they will feed back to us and then we will get into the care home as soon as we can. Even though it was a 5-day response, we look at the referrals as soon as they come in, we look at the blood tests, we look at the medical history, we look at the medication, we look what the referral's for. This lady, it was obvious that she needed to be seen before our referral, our MDTs. So we arranged to go out to see her next day, which was fine with the care home. Because of like reading the referral, and things needed to be done quite urgently, we asked a medic to come with us, which was absolutely fine, and they did. She was a lady in her mid-70s. She got mixed type dementia, so she got Alzheimer's and vascular. There was behavioural and psychological symptoms of dementia. She was having hallucinations, really suspicious and paranoid and tearful. Is it okay to turn the slide, please? Thank you. The risks we identified on the assessment was risk of verbal and physical aggression. She could swear at staff. She could lash out at staff. A lot of the lashing out was when it was either personal care or any intervention, or when she wanted to mobilise. She wanted to mobilise independently. She was very high risk of falls and she needed assistance. So she would lash out because she, like, leave me alone. I want to go on my own kind of thing. Very high risk of fall. She'd had a fall as soon as she'd entered the care home. She'd actually broke her orbital bone. So we liaised with New Cross about that. She was very tearful. She couldn't verbally express herself very well, so we didn't know if she was low in mood or it was emotional. It was a transition into the care home. We believed that she was in quite a lot of pain because she was so agitated and suspicious of staff. She was reluctant to take pain relief. She was at risk of malnutrition because, like, she, again, through agitation, she wouldn't eat or drink, or if she ate or drank, it was very, very slowly because she was very suspicious of staff. There was a risk of placement breakdown. There was a risk of her ongoing psychosis impacting on her overall well-being. She was like screaming out, shouting out. She shouted out a lot for her brother-in-law. She was risking non-compliance with prescribed medication because, like I said, because of the suspiciousness and the paranoia and new environment, not knowing staff, she was very reluctant to take medication, and she was at risk of further physical and mental health deterioration. So those was the risks that we picked up on the assessment. Can we turn the page, please? Thank you. So the interventions we completed medic reviews. There was quite a lot of medic reviews with the medic. Medication reviews. We commenced some medication didn't suit this lady, so it was changed, monitored for side effects. It needed quite a lot of support at the time, so I used to go in daily, and I used to try and time it around medication and meal times. So we got the medication changed to liquid. She slowly built up trust, which was good, so she started accepting off staff. Pain management was a biggie, so I'll come to that when we look at the tools that we utilised next. But we liaised with the GP. The GP surgeries, from the start, we built up a good relationship with them. A lot have got AMPs, some have got like their own Pacific care home staff, and you know, it's quite effective if you can build up those relationships straight away. Life story work, to find out more about this lady. So the staff can find, like, the lady behind the diagnosis, which was really important, and also identify any meaningful activity. We work with the care planning with the staff, the behavioural support and advice. We, like Nick said, we don't provide net education. I would love to, but we haven't got the time at the moment to provide it like macro. And also I've worked in a care home background for 20 something years before coming into the NHS in 2016, and I know the difficulties when there's limited number of staff. If you're providing education to a large amount of staff, where are the staff going to come from to help and assist, or the the residents, you know, so you do have that difficulty. So we provide micro education, but it's education that hopefully the care home take on a board and they can use it with other residents as well. We can signpost places like for the environment if we think that can help, like Stirling University. They've got a fantastic site that they can use for like environment. Ask Eileen in the library, things like that. So we'll signpost that way as well. The person-centred care is so important because everybody's different. So it is like with the life story work, it is kind of promoting the person's choices, their preferences, their likes, their dislikes. It's little things that sometimes make a big difference. We provided the family support. This lady deteriorated quite quickly. She'd been cared for at home by a son and a daughter. A daughter would do the days and the son would do the nights. So we did sort of support the family quite a lot, and then put a referral in for the Admiral nurses with the family's permission, their consent. Can I have the next slide, please? Thank you. The tools we utilised the life story template, the Abbey Pain scale. There was a lot of education in these scales because at first the care staff were frightened to do them because they thought they was going to do something wrong. So it was like empowering them to use these tools. And ironically, a lot of these tools, except the MUS tool, they use that all the time. But a lot of these tools now, if they do know referrals coming in, or if they want to liaise with the GP about anything and that person's not referred to secondary, they'll actually use these tools. So that's really good. So the Abbey Pain scale, which allowed the GP then to review the current pain relief. So this lady actually went right, we followed her right through the pain ladder, and she had a small dose patch in the end. ABC charts. At first, it was difficult to do the ABC charts to identify any triggers because this lady's distress and stress reactions were ongoing. So the staff would constantly have been sat there with an ABC chart. So it was getting them to document it into the nursing notes. And then as the stress and distress reactions got less, then we could complete the ABCs and find any like triggers to the stress and distress reactions and anything that helped like calm this lady in presentation. And the life story helped there as well because we could pull things from the life story. Because she was tearful, we used the Cornell depression scale, which allowed our medics to review for medication and if that medication was working and helping. And we don't advise the care homes to do a MUS tour because they always do a MUS tour. But like when we find that somebody's diet and fluids are affected, then we would also monitor the MUS tour and advise if required. Like, so we do keep an eye on that because sometimes you'll find that, like especially people with dementia, sometimes they won't eat a lot at one meal, but then they will eat quite a lot at another meal. So they maintain their weight. And then obviously, if it is being affected, we would pick it up through the MUS tool. Can I have the next slide, please? Working collaboration. The people we worked with, in particular with this lady, was very closely with the consultant and the medic, very closely with the GP, the AMP and the care homes division, the care home manager and the staff. The care home were fantastic. They wanted to keep this lady. They really wanted to keep her and they really wanted to avoid hospital admission. And at some points in the beginning, this lady was actually on a 2-to-1 and she wasn't actually funded for it at the time. She did go, like as she calmed, to just general observations, which was really good. the local authority and the social worker, because obviously with the social worker, local authority, CHC, they do want our input as well. The family, we worked in collaboration with the family because we're all working together for the same thing, and family so important because they know their loved ones better than anyone. And the Admiral nurses. Can I change the slide, please? Thank you. The outcome. Right, the lady referred following a period of care and support. She settled in mental health presentation and maintained a current placement. I go into this care home often, so over the few years that I've been doing it, sadly, they cared for her till the end. She had multiple infections and then she had COVID in the end, and sadly she passed away. But you know, she did stay in the same placement where they knew her really, really well, and she knew them. So that was really important. She was discharged back to the care of the GP with the recommendation for the GP to refer in the usual manner if further support's required. We do liaise with all our GPs this way because, like, a lot of times it's a deterioration of the disease. So, like, we can pop in when people need it, we can pop back out when they don't. The care home managed all further support in regards to her physical and mental well-being. And we prevented hospital admission as well, which was good for the lady, good for the care home, good for the family. That's me done. Thank you for listening.
Thank you, Angie. And it's always really important to have those case studies, isn't it? And actually to hear, you know, somebody's story, you know, and certainly hopefully that really well done, Angie, in letting people know that obviously the difference that the collaborative work between yourself and the home did for that lady's quality of life. And thank you ever so much for that. I'm acutely aware that. Thank you, Ange. I'm acutely aware that I've run over. It's not my fault. But can I suggest now that we have a 5-minute? Would 5-minute comfort break be okay? Hello, everyone. Sorry, it was a brief 5-minute break. Hopefully, everyone's back. I know we've lost 1 or 2 people, but hopefully they can pick up on the recording later. So, our next thing on the agenda, I don't know if let's have a look.
It's the breakout rooms, Nick.
Yeah. So it's the breakout rooms, and what we're going to do with these breakout rooms is that hopefully you all would have let us know which area you're from, which Sandwell, Wolverhampton, Walsall or Dudley. And if what we're going to do is we will have a facilitator in each of the breakout rooms. And this is an opportunity for you to talk about your local borough, your local area, certainly for those people in those breakout rooms to hear about, you know, what maybe some differences within your local area, and talk about some connections and how and going forward in the future, really, about how you see it working, and also I suppose what's going on at the moment in your area as well, because I've already explained that we're not fully recruited up in all of the areas, etc. So what our tech whiz is going to sort out moving people into breakout rooms, and we'll see you all over on the other side. And then it is for 20 minutes, is it? So hopefully that everyone's now back from their breakout. So did we want to do some feedback? Should we start off with feedback from Wolverhampton, perhaps? Who's feeding back from Wolves? We got Wolves back with us.
It should be Sue, Nick.
While we're waiting for Sue, she may be on some clinical urgent situation or something. So should you have some feedback from yourself then, Colette?
Yes, no
As you-
problem. Okay. So in our breakout room, it was fine, but unfortunately, we just had our team in our breakout room.
Oh, right.
We didn't have anybody, any other stakeholders, but we had a good conversation around a couple of the questions. So what we discussed around our key partners, we identified them as social workers, voluntary sector like Dementia Care UK, GPs, complex care team, the case managers, healthcare assistants that work actually in the care home managers and their team leads, and obviously our general hospitals and those services such as mental health liaison services, just all the inpatient services, and especially where there's sort of the team that do the discharge to assess beds. Okay.
Yeah.
One thing that we identified as very, very important, and probably the most important of all, is family and carers. They really are important key partner when we're working with patients through their journey. We linked in with that, what are our opportunities for collaborating with these other services. So most of our care homes in Walsall, they actually have weekly ward rounds, and in those ward rounds are GPs and case managers. So what we're hoping is to be able to timetable our nurses' schedule, so we link in with those ward rounds and then we can have a collaborative discussion. We also have our place-based teams in Walsall, which is for complex care, and they're held weekly across the whole of Walsall. And there's an opportunity as well for our in-reach to care home nurses to work with those place-based teams. In the place-based teams, there are an array of professionals. There are social prescribers, specialist nurses, occupational therapists, other mental health nurses, GPs. So I think that'd be a really good piece of work to get together and discuss those really complex patients. We identified that actually with our social care colleagues, there isn't much collaboration happening at the moment. It's quite difficult to link in with social workers a lot of the time. So we have considered that it would be an opportunity for us to speak with a senior practitioner and see if there's any scope for them to actually be invited to those ward rounds as well in those care homes. So maybe have one link worker that then can actually work with those care homes. And we also talked about our crisis services within our trust, and for our in-reach nurses to link in with these services for that out of hours support, for our in-reach nurses to do sort of some low-level education and how to support and manage crisis in care homes out of those hours. So then moving on to what digital options do we use? So there's an app being used in Dudley, I believe, at the moment, which is in trial, and that's for the care home staff to use, and it's a snapshot of like 10-minute snapshots and training for staff to how to manage specific behaviours. And I think hopefully that works well, and then we can implement that in all areas. We've also talked about MS Teams being used for those ward rounds, because obviously the ward rounds in the care homes, because obviously it's very difficult for all professionals to get to those meetings with everyone's busy schedules. So MS Teams would probably be a good option, so everyone then can be in attendance. And we've also talked about voluntary sectors such as Dementia UK. They've recently done some training across the area, and all their links are available on YouTube. Yes, it's specific to dementia, but it's very educational, and it's a free resource for care homes to actually be able to link into. We then sort of had 10 seconds to identify what is priority, but I think you can see from what we've discussed, actually a lot of them fit into that final question. There are some things that I will take from this and we will implement locally. But one of the priorities that definitely needs to be addressed is we are getting referrals. We are taking them on because of the crisis situation of the patient, but we are waiting a long time for any of those physical health investigations to happen. And then what we're finding out is actually the patient has an emergency medical need or a delirium, and that should have been treated, 2 weeks ago. So that's something that we need to prioritise. And that's it from us.
That sounds fantastic. Thank you ever so much, all from Walsall. Dudley?
Hello.
I am.
Right. We went off the beaten track a bit. I just asked if there was anything anyone would like to ask and how we could improve the service that we provide, really, which is very important to us at Dudley as well. So it was discussed really about like the referrals coming into CMHT and the difficulty that like especially the GPs have, because like obviously when we ask for physical investigations, if it's a 4-hour response, it's quite difficult for people to leave the GP surgeries due to other commitments and get those physical checks done. And it was just around the importance of them, like, you know, from an Enrich perspective, that it's also difficult because if we was to respond without like the physical health checks being done, then, you know, our consultants or our medics or who we'd liaise with, especially in a crisis, they would be very reluctant to, you know, recommend any medication or anything because, you know, so it would be really difficult that way. It was about the clinical up. The clinical up, sometimes they refer to Michelle and sometimes they will kind of ask the GP to refer. So like, would it be better and improved if the clinical up could actually refer directly? I know it goes to Michelle a lot of the time from clinical up, and Michelle will refer in and she'll follow that up with a phone call if it's someone that needs to be seen urgently. So we was discussing that and was discussing like a lot of the care homes, like physical health. It's the education, isn't it, for them to rule out some of the physical health. You know, do we actually need mental health? Do we actually need physical health review? Because we're saying the difficulties with like the care homes now. A lot of care homes have been stopped from doing observations, especially the residential. And you know, they can't do the BP, they can't do the urine analysis anymore. You know, and it's looking at that education around that. Is it a delirium? Is it, you know, is it the mental health deterioration? So it's looking at that kind of thing.
Yeah, that's good. Thank you, Angela. Cheers.
Thank you.
Okay, I'll talk for Sandwell. Our group was quite a small group, but it was really, really good. It seemed to be pretty much a complete group. We had psychology, we had an in-reach worker, we had a care home shift coordinator, we had a social care lead and also health primary care lead as well, which was really, really fantastic. And a lot of our discussions were around the collaboration of the InReach workers, and probably building on what Colette was saying earlier about how will InReach now work very, very closely with our social care colleagues. And there are some really big challenges hearing from the care home member of staff. They were talking about the level of acuity and the level of need around people's presentation in the care home seems to be higher now than it probably ever has been. Listening to local authority, there is a lot more people on one-to-one and quite restrictive one-to-one, obviously, care for people because of that, and likewise from health as well, trying to understand, you know, people's complex needs in health as well. So it was really, really welcomed in our breakout, the introduction of the InReach to care home workers, and we did discuss about how collaboratively we could work together closely. And I suppose being in each place, we need to look at, in the same discussions I've had in Warsaw, we didn't actually get to talk about the details in Sandwell and what type of forums there are in Sandwell that the in-reach to workers can be part of and privy to, that building relationships with those other very, very close frontline people. I was about to, but we overran, unfortunately. I was about to ask about digital options, but this forum is an ideal opportunity. Nothing will replace the in-reach to care home workers' intervention face-to-face with the service, with the resident in the care home and with staff within the care home. But if there are opportunities, as has been said in Walsall, I think that's probably something that I think for our local authority and our primary care and the care home, that's something that perhaps we could look at for Sandwell in how we would be able to enhance that communication. And was there anything else, anyone from our breakout that I've probably missed or anything? Is there anything else that anybody wanted to pick up? No, it was very, very positive though, which was really, really good to hear. And certainly our psychologist Anne is already ready to make some contact with people as well. She was taking, hopefully she'll be speaking to people about. We were talking very much around some of the behaviour, certain like behavioural and psychological symptoms of dementia, which she was really very, very interested in, where maybe some further support for people could come through that. Anyone in Wolverhampton?
Yes.
I know there's
Sorry,
lots of people in
I
Wolverhampton.
got kicked out.
Oh, kicked out. I thought you'd got a very urgent clinical call or something.
No, I could have said that, couldn't I? But I just got kicked out. So we discussed mainly about what the ECMHT is, what's based at Wolverhampton, the hours that we work, how to refer in. The only question I did have though, are we having a specific referral form for the care homes, or is it just a generic into the ECMHT?
It's the same.
That's
into
what
the
I
ECMHT.
thought. Yeah, because then it'll be picked up. Yeah. And then there was a question whether the NMPs can refer into services, because as far as I'm aware, it's just GPs.
I think that's again, we've heard, I think, was it Walsall saying about, no, Dudley was saying about how their integrated enhanced care team, where Michelle Davis as that mental health individual, that is something that we probably will have to look at going forward as part of that. We've got to sign off a service specification, so there is going to have to be that, and looking at referral back as well, because I know that there's a keenness to have self-referral for people, isn't there? I know that certainly in Dudley, if somebody was in the ECMHT and they were relapsing after being discharged from the ECMHT, I think there was 3 months that within 3 months you could self-refer back. And things like that, to really try and remove some of those boundaries and barricades into other services and stuff like that, which are there for a purpose. That we heard from Angela, the really important thing around physical health and discounting physical health. But I certainly would like to take that away from this around. We've got our ECMHT work we're doing as well, isn't it, to look at that as referrals into ECMHT and ultimately into InReach. But thank you, we can take that as a really big question, isn't it, from today.
And then the other question raised was about IT, what IT we're going to have to support. But Tracy has already sent me the link of somebody that I'll forward on to you and Colleen, Nick, to see what's available in Wolverhampton and whether we'd be able to link up to anything that they're already using.
Yes, and certainly that pilot that's happening in Dudley, with regards to that support for care homes, that'll be really interesting if we could look at rolling that across all 4 boroughs. That's something that Vibha, Pavan Kumar, the psychologist in Dudley, have been working on and launching with the team there, and Angela, etc. So it's more exciting. And although when we launched InReach to care homes, just for everybody on the call, we've been having very regular project meetings. Those project meetings will continue following launch, obviously, to continue to develop the service as well, and pulling in a lot of this action into there to make sure we actually do see through some of these actions and questions that have been raised as well. So those are all of our 4 boroughs. Please, I haven't missed anyone. No, I haven't. So that's I'm acutely aware this was until 11:30 today. We've got lots and lots of questions and answers. Oh, sorry, lots and lots of questions probably that have come into the chat. And I promise that one of the things I'll do is I'll go through all of those. And when we circulate the PowerPoint and other things from today, then we'll make sure, and the recording obviously, then we'll make sure that I've got the answers to or what I'm going to do with those questions to people when we filter it through, because there's probably a lot of questions there in the chat as well. Are there any questions that anybody would want to raise now about any other further questions or pressing verbal questions that anyone would like to raise now who are on the call about in reach to care homes across the Black Country going forwards? No. Okay, so as I've said, our priority is recruitment at the moment to get our last posts in, and we've got 3 candidates for 3 jobs. So I'm forever the optimist that I'm hoping that we will have those people in post. It's great news that the psychology assistants will all be in post by the 8th of August. The 2 of them will be in by the 8th of August. At a time like this at the moment, with so much community transformation going on, that it is very, very difficult to actually it's very, very difficult to actually recruit in a number of posts at the moment. But for whatever reason, and I'd like to think it's because it's a fantastic opportunity and a fantastic service that this is going to be rolling forward and developing further, that we are looking like, from launching the recruitment only probably around April time, by September, in the current climate, we could be fully, September, October, we could be fully staffed, which is actually fantastic news. Our priorities and our future plans is to keep talking to our partners. It's been such a 2 years, 2.5 years, whatever, not only for obviously the pandemic, which has been huge, but the trust has gone through merger, the CCGs, the local authorities, everything seems to have changed in our world in the last 2 years and coincided. But the priorities for us is to really to keep the ties and hopefully some of the communication and some of the networking and the links with partners that we've had from people coming to this event today and future events as well, because we'd like to also repeat this type of update maybe in 6 months, maybe in a year's time, because then we'll really get some great feedback as well, won't we? Because then every area will have experienced in reach to care homes by then, one would hope. And one would hope it will be as positive as we found it has been so far in Dudley as well. So unless there's any other questions or any other comments. Yeah, thank you for listening. And I've sort of done any other questions a bit back to front actually. So and the last slide there, yeah, hopefully that will be supportive as well. Yeah, is everyone okay then? And isn't it great that it's a bit cooler? It's still nice weather, but it's a bit cooler. If we'd been doing this yesterday, you would have seen me probably swaying. So I'm so pleased with the timing from our comms team and everything that they chose today instead of the hottest day ever yesterday. So thank you everyone for all of your time and commitment, and people who'll get to know me. I'm very, very positive with a lot of things, and especially around this in reach to care home work, and hopefully we'll engage and speak and meet with you soon. My helicopter, if you can hear, has just arrived to take me away, and can you hear that? Hopefully it's not throwing water on the gardens or something, but we'll speak to you all soon, and take care and have a good day. Thank you.
Bye.
Bye all.